So if you're in the world of cardiovascular medicine, or even just follow it, you know the name. Atrial fibrillation.
AF, yeah.
It's a constant worry, that irregular heartbeat, and the biggest danger, of course, is stroke. It's a major, major cause.
Absolutely. And for years, our main line of defense has been oral anticoagulants, OACs.
Right, what most of us just call blood thinners. They're the standard of care, the absolute bedrock of prevention.
They are.
But here's the question we're really digging into today, and it's a critical one. What happens after a patient has already had that stroke and they are now, diligently taking their medication? Are they actually safe?
That is the entire mission of this deep dive. We're looking past the first event. We're trying to quantify this residual risk, the chance of another stroke, even when someone is doing everything right.
And the systematic review we're looking at today, it gives us a pretty sobering answer to that question.
It does. It's a massive knowledge gap this study is filling.
And when you say systematic review, you mean it. The sources you sent over, they pulled data from everywhere. Ovid Medline, Embase, searching records from, 1946, all the way to January 2025.
It's an incredible scope.
It's not a small survey. We're talking about 23 different studies, over 78,000 patients, and get this, more than 140,000 patient years of follow-up.
That scale is so important. It lets us trust the numbers, especially when we're talking about such a high-stakes group of people, stroke survivors.
Right.
The whole point here for you listening is to understand what happens after we've prescribed what we think is the best possible defense.
And a key piece of context from the researchers really stood out to me.
Which was?
In these studies, the median number of patients actively taking their OACs was super high, 92%.
Exactly. So the recurrent strokes we're about to talk about, they happen despite near universal use of modern therapy.
So this isn't a story about patients not taking their medicine.
Not at all. It's a story about the medicine itself, in some cases, just not being enough.
That, right there, makes me think we've been maybe a little too confident in the protection these drugs offer after that first event.
It's a fair assumption to question.
Okay, let's unpack the core finding then. The primary outcome: recurrent ischemic stroke. The one caused by a clot.
Yep, the big one.
Based on all that pooled data, they found the baseline recurrence rate is 3.75% per year.
And, 3.75% on its own as an annual number, it might not sound that dramatic to you.
No, it sounds kind of small.
Yeah.
But that's the trap with percentages, isn't it? They hide the real human cost.
They absolutely do. And the statistics behind this are solid. The confidence interval was tight, between 3.17% and 4.33%. They're very sure about this number.
But accuracy isn't the same as impact. The real aha moment for me was when they translated that annual rate into a long-term reality for a patient.
Right, when you project it forward.
If you take that 3.75% rate and run it over 5 years, the conclusion is just staggering. 1 in 6 patients has another ischemic stroke.
1 in 6, let that sink in.
It's terrifying.
It is. If your main prevention strategy still fails 1 out of every 6 times over 5 years, you have to reevaluate what prevention even means for this group.
The study's authors flat out say this residual risk is high, even with our best modern therapy.
It completely challenges that idea that once you're on a blood thinner, the main danger is over.
Clearly not. It seems the underlying biology of AF is just more powerful than the medication in some people.
It's driving risk in ways that just thinning the blood can't fully stop.
Okay, so that 3.75% is the average. But things get even more interesting when they start slicing up the data based on where it came from, right?
Yeah, this is where it gets really fascinating. They found a huge difference between different kinds of studies.
Which raises all sorts of questions about who's being studied and how that applies to the real world.
Precisely. They compared non-interventional observational cohorts.
Okay, so that's basically real-world data, just watching patients in clinics.
Exactly. The messy everyday reality. They compared that to randomized clinical trials, RCTs, and the difference was highly statistically significant.
So let's hear the numbers. In those real-world observational groups.
The risk was higher. It jumped to 4.20% per year.
Okay. And then in the super-controlled setting of a clinical trial.
Dramatically lower, 2.26% per year.
Wow. That's nearly half the risk. Why such a huge gap between the real world and a clinical trial?
This is such a crucial point for you to understand whenever you're reading about medical research. RCTs are designed to be perfect.
Ideal conditions.
Ideal conditions, ideal patients. They often screen out people who are too old, too sick, or have other health problems. The patients are monitored like hawks.
But observational studies.
That's real life. It includes the older patients, the ones with uncontrolled diabetes or hypertension, all the things that also contribute to stroke risk. So that 4.2%, that's probably much closer to the true risk that doctors are dealing with in their clinics every day.
So the trial gives you the drug's best case scenario, but the observational data tells you the real severity of the disease out in the wild.
You've got it. It's a critical distinction to make.
And of course, we can't talk about blood thinners without talking about the other side of the coin, the bleeding risk.
The trade-off, it's always a balance.
The study looked at that too, the secondary outcomes.
Yes. If you broaden the picture beyond just clots and you look at any recurrent stroke, so that's an ischemic one, or a brain bleed, an intracerebral hemorrhage, the risk was 4.88% per year.
Almost 5%. 1 in 20 patients having a major brain event every single year.
It's a heavy burden. And if you isolate just the brain bleed risk, the ICH, that was quantified at 0.58% per year.
Which you'd hope would be much lower than the clotting risk.
It is, thankfully, but it's still a constant low-level danger that has to be managed.
Okay, but this is where, for me, the analysis got truly eye-opening. The researchers didn't stop with the average. They zoomed in on one specific and profoundly challenging group of patients, the ones whose first stroke happened while they were already taking an OAC.
This is the treatment-resistant group. Think about that. They had a stroke while on the very medication designed to prevent that exact event.
They've already proven that standard therapy isn't enough for them.
They are the absolute definition of a failure point in our current strategy. And this is where you see the highest risk of all.
And when you look at just this group, the OAC failure cohort, the numbers stop being academic and they just become, well, truly alarming.
They really do.
For these patients, the ischemic stroke risk, it jumps from that 3.75% average all the way to 7.20% per year.
7.2%. It's nearly double the baseline risk. It shows just how vulnerable this group really is. The confidence interval is wide but still very high, from about 5% to over 9%. And
what about any kind of stroke for this group, clots or bleeds?
That risk is even higher. The chance of any stroke hits 8.96% per year.
That is approaching 1 in 10. 1 in 10 of these patients having another major event every year.
It's a number that demands a different therapeutic approach, urgently.
And that unavoidable trade-off, the bleeding risk, it follows right along, doesn't it?
It does. For this very high-risk group, the danger of a major brain bleed, the ICH risk, it also goes up significantly. It rises to 1.42% per year.
More than double the rate in the general post-stroke population.
And if you connect all these dots, the big picture is that for a really significant number of AF patients, our standard therapy is just not sufficient for secondary prevention. This isn't about taking your pills. It's about a deep, treatment-resistant biology.
So let's boil this all down. What does this mean for you, the person listening, who wants to be really well informed on this?
What's the takeaway?
The central finding we have to repeat is just so clear. Despite almost everyone taking modern blood thinners, the risk of another stroke is alarmingly high.
That 1 in 6 number over 5 years.
That's the one that should be driving research. It's unforgettable.
And it leads directly to the call to action from the study's authors. They lay out 3 key areas we have to tackle immediately.
Okay, what's the first one?
First, we have to get a much deeper understanding of the biological processes. Why is a stroke still happening when we think we've suppressed the main clot-forming pathway? What are we missing?
Is it inflammation? Is it something about the heart structure itself?
Exactly. We need answers that go beyond just basic blood chemistry. Second, and this is huge for doctors in the clinic, we have to get better at risk stratification.
So figuring out who is in that super high-risk group before they have their second stroke.
Yes. We need better tools, maybe imaging, maybe biomarkers, to identify who needs more than just the standard therapy. We shouldn't wait for the treatment to fail to know who is at the highest risk.
And the third point?
We urgently need to develop new secondary prevention strategies, things that could be added on top of OACs, or for that highest risk group, maybe even replace them entirely to really bring down this devastating risk.
Which brings us to the final thought to leave you with.
Right. And it's a big one. Think about it. Our oral anticoagulants are designed to do one primary thing: stop clots from forming. They target the coagulation cascade. The fact that the risk stays so incredibly high, especially in that group that already failed therapy once, it strongly suggests that something else is going on, something that isn't just about clotting.
So if thinning the blood isn't enough,
Then what fundamental biological or hemodynamic process related to AF itself are we completely missing? Is it chronic inflammation? Is it something about blood flow dynamics in the heart? What is it that our current therapy isn't even touching? Answering that question, that's
Yeah.
what will truly revolutionize how we prevent the next stroke.